Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
I'm going to talk mostly about ankle problems today and Achilles tendonitis. There's a couple pictures. This is probably the worst one. So I'm from Wisconsin, so I'm a big Brewers and Green Bay Packer fan. So you'll get some references in here today. But ankle sprains, which kind of leads into chronic ankle sprains or ankle instability, ankle arthritis, and Achilles tendon problems is what we'll talk about today. The first question that I get a lot is, when should you come in and see a doctor for, when your ankle's hurting? And, some real basic guidelines. I mean, there's, every situation's going to be a little different. But if you can't walk on it, if it's really swollen like this guy here, if you notice any angular problems or any bones sticking out, pushing up against the skin, definitely get in. And if it doesn't improve within a couple days, if you still can't walk on it, then you really should get it checked out because it usually indicates it's something pretty serious. So ankle sprains are incredibly common. There's over 2 million each year just in the U.S. alone, and these account for 20% of all sports injuries. And 85% of all the ankle injuries sustained in the U.S. are ankle sprains. So we just see it all the time. This guy, I don't think he sprained it. He actually broke it, but it just looked good. So this is what comes into the office a lot. I mean, if you have something like this, you should get it checked out. This is a perfect example. Now, inadequate treatment of ankle sprains causes really, really big problems, and I see it every day. I saw it this morning. I had a patient that had a bad ankle sprain a year ago, and he's still having pain because he didn't have adequate treatment for it right away. He never got it checked out. What happens is you get chronic ankle stiffness and ankle pain, and you might be able to walk, but you can't do any higher impact activities like running or anything like that. You can limp and have some joint instability where your ankle feels like it gives way often. It feels pretty weak. So this is a really important slide because I'm going to talk a lot about the ligaments. And so what exactly happens in an ankle sprain? Everyone hears the term ankle sprain, foot sprain, you can sprain anything. But what really happens is there are these little ligaments, which are little rope-like structures that connect the bones of your leg to the bones of your foot, and specifically the fibula to the talus and the calcaneus here. And when you twist your ankle, like up on the top here, this guy, when you don't twist it that far, it just stretches them. Usually not a big deal. People can usually walk after that, But when you start to twist your ankle even farther like this or like this guy over here, you actually start to tear the ligaments. And that's what a sprain is, So anywhere you get a sprain, that's exactly what it is. It's a ligament injury. And so there's varying degrees. Not all ankle sprains are created equally. Some people can walk right away. Some people aren't going to be able to put weight on it for a couple weeks or even a month. So treatment for these acute sprains. The key here is you have to immobilize the ankle. You can't let your ankle continue to move, and you can't try to walk it off or keep playing your sports when it's still hurting, because these ligaments just won't come back together if you do that. And that's when we really run into problems. So, I mean, the mainstay when people can't walk is I usually put them in a boot or even a cast sometimes. This is just for non-compliant patients that don't listen. Then eventually we go to a brace. And that's a little more functional. You can actually move your ankle up and down, but usually start with something like this. This is like a walking cast. You can walk on it, but it allows your ligaments to heal. The next thing with treatment for acute ankle sprains is you have to do some physical therapy, either at home or go to a physical therapist. Most people are at a much higher risk of re-spraining their ankle within a year of a bad ankle sprain. And the reason is the little nerve fibers that connect to the outside of your ankle joint are injured at the same time. And if you don't retrain yourself balance-wise, chances are you'll sprain your ankle again. So physical therapy is really important for that. Now, the question I get all the time is what happens if the ligaments don't heal? And they don't. And that's what people always ask when they come in a year afterwards, when they haven't treated it appropriately. You can get what's called chronic ankle instability. So on the left, you have a normal ankle. You can see everything's aligned. The joint looks lined up great, okay? On the right, you can see that it's not. I mean, the angulation is off. It's 15 or 20 degrees off. And the ligaments that we talked about are over here. They're supposed to connect this bone to this bone together, right? And obviously they're not functioning well. And the problem with this is, not only can you sprain your ankle and it continues to hurt, but you can develop arthritis in your ankle if this is left untreated. So that gets to the next step. We were talking a little bit about ankle instability. But what ankle instability really is these ligaments are now stretched out. They're like a rubber band that's a little too stretched out. And they're just, they're allowing you, these ligaments right here are basically allowing your ankle to do this motion, which is just a inappropriate motion because you're going to get uneven wear on the joint. So this is like the guy that came in this morning, continued ankle pain and swelling. Ankle felt really weak. He keeps spraining it over and over and over again. So when people come to my office, I evaluate this in a couple different ways. For really bad ones, sometimes we'll get an MRI or a special x-ray where I'm actually doing this maneuver and holding your ankle in this position to see how far it goes, and I can measure it. We have a digital x-ray thing we use to measure it. And that's this one right here. I don't know what okay, here. Also, we can kind of translate your foot forward because that's one of the other functions of the ligaments, to prevent your ankle from popping forward like that. And so I usually compare it to the uninjured ankle, and usually there's a pretty significant difference if there is instability. Now, ankle instability, it's a spectrum. It's not instability or no instability. It's usually on like a 1 through 10. You can think of it that way. Some people have mild instability. It's not usually a problem. The ones that develop arthritis are the ones that usually have really bad instability. So treatments for this are similar to an ankle sprain, but we don't need the boot usually right away. Usually we focus on the proprioceptive training or the balance training. And here's a guy on a balance board, and basically it's a really wobbly board, and that's actually pretty hard to do even if you don't have a sprained ankle. But you can start slow and hold on to something. And here's another example of it. But the brace is great, and what the brace does is it doesn't let your ankle twist or invert or evert, but it allows your ankle to go up and down. So basically the brace does what the ligaments are supposed to do, but they're not doing because they're not functioning correctly. You can also use anti-inflammatories for swelling, but that's not going to fix it. Now, the problem with all of these treatments here is they actually don't fix the ligaments. Physical therapy doesn't actually tighten the ligaments, and wearing the brace won't actually tighten the ligaments. The brace will just, do the same thing that the ligaments do. It'll act as a ligament for you. You can't wear it all the time. And so the goals of conservative treatment for ankle instability are to, improve your balance and prevent future sprains and improve your function. But some people, the ankle instability is just too severe. And I have so many patients that they say they can't even walk down the sidewalk without having their eyes fixed on the cement to make sure that there's not an uneven surface. I mean, that's when you know you really have a problem. So fortunately, this is something that's very commonly done. Is fixing the ligaments on the ankle. It's pretty simple surgery. It's an outpatient surgery, and it's really successful, like over 90% successful. I've actually had better results than 90%, but that's, if you read all the articles, it's about 90%. And what we do really is just tighten the ligaments back up, put a couple of stitches in there, and we use a little dissolving piece that goes into the fibula. And then we take some of this extra tissue called the retinaculum and kind of cover the whole repair to make it a little bit extra strong. So basically we just repair and tighten the ligaments. Now afterwards, you get to have a nice cast on, any color you want, for about 4 weeks. And you have to use crutches. You can't put any weight on it. The problem is if you put weight on it, the ligaments will just stretch back out again. So for at least 4 weeks, you have to keep pressure off it. And then you get to go to the old boot, for another 3 or 4 weeks afterwards. It takes 6 to 8 weeks for the ligaments to heal. I don't know if you guys watched the Super Bowl, but Donald Driver was wearing one of these, in the second half. Is just like this one actually. And then eventually you do some physical therapy and wear an ankle brace afterwards. So the next thing we'll talk about is ankle arthritis, and this is what happens when when basically the lining of the joint wears out, and the joint is lined with this cartilage or this soft material that protects and cushions the bones, and it basically prevents the bones from just grinding on each other. It's what gives you the smooth feel of your ankle joint. Right? And this is Brett Favre. He's pretty famous for having ankle arthritis. He had at least 1 surgery for this in the off season, maybe 2, where they had to clean up his ankle for this thing. So what patients usually complain of is chronic pain and stiffness in the joint, as opposed to the instability. They don't really have instability with this, but you have swelling like at the front and at the back of the joint. And the real problem is difficulty walking. A lot of times you'll move the ankle joint and you'll kind of feel it kind of grinding. That's usually arthritis because normal cartilage won't do that. Also, a lot of times people feel or notice bone spurs on the front or on the sides of their ankle. And that's just extra bone buildup or calcium buildup around the edges of the joint. Most commonly, people, yeah, this is probably the worst one. I should. Most commonly, people get ankle arthritis after they break their ankle. This guy's going to get arthritis almost for sure. Probably 80% chance he'll get arthritis in his ankle. When you damage the joint so severely, it wears out. Now, this is different from like knee arthritis. Knee arthritis, it's normally just a wear and tear type osteoarthritis. I mean, sure, you can get it with an injury, but a lot more commonly you just get it with just everyday use and wear and tear. This 80% of the time it's going to come from an injury. Also, ankle instability will cause this. Less often than a fracture, but it will cause it. Rheumatoid arthritis and infection are a couple other things that'll cause arthritis, and these can cause arthritis anywhere. So treatments for this. You can start with anti-inflammatories, which are pretty helpful, like Advil and Aleve, ibuprofen. Bracing. For some people, we get this custom brace. This is called an Arizona brace, and it's basically we make a mold of your whole foot and ankle, and this brace has got a hard polypropylene shell with like a leather liner on it, and it really can stabilize your ankle. Basically, your ankle doesn't move. It's kind of like a little mini cast that fits inside of a shoe. It can actually work pretty good. It's kind of a pain to get on and off, and it's a pain to fit into shoe gear, but it really helps the function because it's not going to allow your ankle to move at all. And that's the key, because if you can stop your ankle from moving, it'll stop the ankle joint from grinding. It seems kind of a drastic thing to wear as a brace like that, but the surgeries for ankle arthritis aren't that fantastic, so we'll get to that in a minute. Cortisone shots can be great for this. You can have 1 or 2 in a year, and that can really help. A lot of people get a really good pain relief from this. I just had a guy last week. He had pain for several years. We took an X-ray. He had ankle arthritis. Gave him a cortisone shot. And he walked out really happy. And I don't worry so much about the steroid wearing out the joint because the joint's already kind of worn out. I mean, it already has some major problems with it if it's hurting that bad. Physical therapy can be helpful for range of motion improvement because ankles that have arthritis get really stiff. Now, a couple new things that we can talk about are, it's called the viscose supplementation, and this is kind of stealing this from some knee arthritis literature. I've done this a few times in the ankle. Problem is insurance companies don't really cover it that much yet, but basically what you try to do is inject hyaluronic acid, or you're basically like changing the oil in your ankle joint. That's a way to think of it. The fluid in your ankle joint, when you have arthritis, has less of this hyaluronic acid, and it helps to kind of nourish the cartilage and make it a smoother surface so you're not getting as much grinding. It can be really helpful for some people. They're just doing studies on this in the ankle now. They want to do the knee first because it's a lot more common. Another option is cartilage replacement. Okay, so this is actually where this is really on the forefront, and it hasn't been approved for the ankle yet, and it's not commonly done. I think this is what we'll see in the future for a lot of different arthritis treatments. It's actually where they take out some cartilage from your joint, and then they grow it into a lab, and then you get a nice big piece of it and then replace it back into your joint. Now, it doesn't work so well with post-traumatic or arthritis that's from after an injury. That's why they're doing it in the knee more. It's more for wear and tear type arthritis. But it's still got a little ways to go. But that's really the only treatment out there that's actually working to fix the underlying problem, where you're actually replacing the cartilage that has been eroded or lost. So one thing that we try for arthritis is you can clean up the joint. And we do this arthroscopically now, which is great because you have a 2.7 millimeter camera. So this is a tiny, tiny camera. And you make like a 5 millimeter incision here and 5 millimeters here. So it's really small incisions, only 1 stitch each. You can kind of see them, they're looking inside. And his ankle looks all orange because there's a light attached to the camera. It's not on fire or anything. And you can actually go in and clean up bone spurs and clean up small areas of arthritis that you see there. Now, this isn't so great for really, really bad arthritis. But for some people, there's really not a lot of other things you can do besides like end-stage procedures, which we'll get to next. So basically, this bottom one here is there's some inflammation in the joint, and this is the tibia on the top, and this is the talus on the bottom. So this is the ankle joint right in between here. And what you see is just a bunch of inflamed tissue that's stuck or wedged in between the two bones. Now the one on top, the white here is normal cartilage, and this pinkish color is actually, it's just worn out. That's bone. It's just bone, you know, and you're just getting bone grinding on bone in that area. And so what we do, if you guys watch like any like professional like basketball, you hear a lot of these guys getting microfracture on their knee. This is a similar thing. What we do is put tiny little holes in here, which allow like the bone marrow cells and blood from the inside of the bone to try to stimulate new cartilage growth in this area. Basically, it kind of bleeds and then it fills in. And now it's different than the normal cartilage, though. It's not the same thing as this hyaline cartilage. It's called fibrocartilage, is what gets produced here. But it is better than having just a bare piece of bone there. So you can kind of clean up the joint with ankle arthroscopy, but it's not great for really bad arthritis. So the reason we try all these, you know, kind of odd techniques like the brace and the arthroscopy and everything is because for severe arthritis, the treatments, you know, really aren't that fantastic yet. You know, it's really, you know, you can replace the ankle joint or you can fuse it together. It sounds awful to fuse the ankle joint, but actually patients are really happy with it. I try not to do it. I try to avoid this, you know, at all costs. But some patients, if you can't walk, you can't walk, and you're better off to be able to walk with your ankle kind of at a fixed 90-degree angle than to not walk at all. And your ankle can actually, I mean, the joints past your ankle still move, so you still have some motion. But basically, what you have to do is remove the joint surfaces and put the two bones together, and that's what the fusion is. But when you remove the joint surfaces, you don't have any pain anymore, usually. Because there's no joint, there's no bone grinding on bone and no motion there. So the benefit is usually the pain is completely gone. I've had patients I had a guy that he got in a motorcycle accident, really bad arthritis, had this for like 20 years and he just didn't want to have it fixed. Finally we fixed it and he was so happy, and the first thing he said was, well, why didn't you tell me to do this sooner? You know, but the disadvantage though is you lose motion. But usually by the time people need an ankle fusion, they don't have much motion anyway. So it's really not, I mean, you're only going to lose a couple degrees of motion. It's not a huge loss. Now, ankle replacements are kind of, there's a lot of new research and a lot of new techniques. They came out, 20 or 30 years ago, and they weren't really that great, and a lot of them failed. The implant designs are improving a lot, and they're actually getting a lot better recently. There's not a lot of places that do a lot of these, but they are improving. And basically, this is similar to a knee replacement or a hip replacement. The problem is the ankle joint is so much smaller than your knee and hip, but you have a lot more force on that area, and that's why these have a higher failure rate than knee and hip replacements. Although new ones are dispersing the pressure a lot better. The problem with the newer ones is they haven't been out that long, of course. And so the long-term studies aren't really there yet. And you have to be really careful in the indications for ankle replacement. For younger people, it's not really an option because, it'll probably fail, during their lifetime. But for older people, it can be helpful. All right, so just behind the ankle joint is the Achilles tendon. And the Achilles tendon actually hooks onto the back of the heel, and it's basically starts up in your calf. It's your calf muscle eventually ends and then becomes this long, thick band, or the tendon, okay? It's made up of the gastrocnemius and the soleus muscles. Those two come together and become the Achilles tendon. Really common problem, especially for athletes. And what happens is you get overuse, like people that are training for a marathon or playing a lot of soccer. I just had a soccer player that had this. Or you can also get calcifications in the tendon. It's such a big tendon and it's got such a big job that where the tendon hooks onto the bone, you can get like these little bone spurs that form. And usually what people complain of is they'll get up in the morning, and when they first start walking, the back of their leg hurts. Or if they first start running, the back of their leg hurts. As it warms up, it gets a little bit better. But then throughout the day, when they get really active, it starts hurting more. Two main areas of problems are the Achilles tendon about 3 to 6 centimeters above the heel. That's a really common spot for runners or anyone doing any high impact activities. And then older people usually get little spurs right where the Achilles hooks onto the bone. This can be a really big problem because anytime you're walking, your Achilles has a lot of force transmitting through it, and this little bone spur in here is just kind of grinding on the tendon, causing this chronic inflammation. I actually think I see more here than I do up here. You can also get some chronic thickening of the tendon, in this area. So here's a picture of Achilles tendonitis with the insertional calcification. You got a little spur here, and then these calcifications right in the tendon. And these just cause irritation. This is actually really common. And so treatments for these, a lot of the same things actually as ankle sprains, is immobilizing it. If you don't let the ankle move, it won't allow the Achilles to move, and it'll let it temporarily improve. Anti-inflammatories like Advil and Aleve are great. Physical therapy can be great too. This one, we really avoid cortisone shots. Cortisone shots can actually cause you to rupture your Achilles tendon. Some people will beg me to do it, but then I'll say, all right, we'll do a cortisone shot, but you have to be in a boot for a month afterwards, But I really try to avoid it unless someone really needs it for, for whatever reason, or if they can't have it fixed. Now, a couple new treatments for this are PRP injections, or platelet-rich plasma. That's what Tiger Woods had in his knee. I think he had it at least once, maybe twice in his knee. And I'll tell you about that one in a second. Also, there's a high-powered ultrasound unit that we use. And we use this for plantar fasciitis, but you can also use it for the back of the heel. So PRP injections, this looks kind of gross, but this is just like some tape they have on the back of the guy's leg. He's not bleeding or anything. So what you do is you basically draw someone's blood and you spin it down in a centrifuge. And then basically that isolates the platelets. And the platelets are the part of the blood that gives you all of your growth factors and healing factors, right? So you have this super concentrated mix of growth factors, and then you can inject that into the area of, of the tendon problem. Some people use it for arthritis, although I don't know if it's quite there for that yet. Some people use it for that. Actually, some people use it for plantar fasciitis too. And what it's supposed to do is allow the tendon or the ligament or whatever you're injecting to heal really rapidly on its own. And it's basically using your own blood products. You're not using someone else's or any cadaver tissue or anything like that. It's just a shot. That's all it is, really. The other thing is, now here's where the plantar fasciitis would be on the bottom. That's where people get a lot of pain, really common. The shockwave therapy is the same, basically the same instrument you use to blast a kidney stone. It's a really high-powered ultrasound unit. It actually hurts. You have to be sleeping for this. It hurts too much. And you can use it on the bottom of the heel for plantar fasciitis or at the back of the heel for the insertional Achilles tendonitis. I don't know if you'd want to use it higher up, probably not, but where the big spur is, you can use it. And basically the technique here is you want to use these high-powered sound waves to try to stimulate new blood cell formation in the area. We call it angiogenesis, but it basically just means new arteries are basically being created with this high-powered ultrasound, and when you have more blood supply to the area, your body can heal things a lot better. Now the problem with this spur and this calcification is the PRP injection doesn't break it down, and the shockwave therapy doesn't get rid of it and break it down like it would a kidney stone. So when it's really bad, when people get to the point where they can't walk, then that's when you can take it out. And basically what we do for this one is just remove the spur, kind of smooth everything out back here, and now that's the easy part, okay? Now the difficult part is you have to allow the tendon to heal back to the bone, and so that's different. When tendon has to heal back to a tendon, when you rupture a tendon, that's fine. It's just like to like. Or when a bone breaks, two edges of bone have to heal. But this one, the tendon actually has to hook back into the bone, and that can really take a long time to heal. So for this one, it's a similar thing. 4 weeks in a cast. That's not my cat. I just found that one on the internet. Just thought it looked funny. Yeah. 4 weeks in a boot, and then you got to do some physical therapy afterwards. But the main thing is, while most of these patients do great, it can take up to a full year to feel really good with this because the tendon fibers, the soft tissue fibers, actually have to hook back into the bone. We have some new anchors that we use, which are little dissolving pieces that help the tendon attach back to the bone. But even with all this new stuff, it still takes a while to get better. Although you can be walking on it, in 4 weeks with your boot, and usually pretty comfortable. And yeah, I grew up a half an hour from Green Bay, so I'm a huge cheesehead. So yeah. Any questions?
Hello. Beside the shockwave therapy for plantar fasciitis,
Yeah.
what are the other treatments available?
Oh, okay, yeah. Plantar fasciitis. The great thing about plantar fasciitis is you can usually get it to go away, 90 to 95% of the time. The problem is there's so many people that have plantar fasciitis, there's going to be a small subset of people that we can't get it to go away. So what we usually try, orthotics are great, or arch supports, Basically we make a mold of your foot. You can do the custom ones or just over-the-counter ones. I think custom ones work a little bit better, but this literature is kind of mixed on that. Night splints can be helpful, basically to help stretch the fascia all night. A huge treatment that people always overlook is just don't walk barefoot ever, you know, when you have plantar fasciitis. And that includes just wearing a sock or just a slipper. You got to have like a supportive shoe. The two main goals of all your plantar fasciitis treatment are, one is to get the inflammation down with like anti-inflammatories, icing, ultrasound, things like that, physical therapy. And two is to give you your plantar fascia as much support as you can get. And I just found that people that have like long-term plantar fasciitis are either people that stand all day, they used to work at NUMMI. I used to see it all the time when NUMMI was still running. They would be standing 8 or 12 hours a day. Or people that walk around the house with, without shoes on. I usually recommend wearing like some Birkenstock sandals or something, some sandal that's got an arch support. I mean, I'm the same way. I take my shoes off the first thing I do when I get home, but I don't have that problem right now. I've had it. And when you do have it, you just have to give yourself as much support as you can all the time, Yeah. So cortisone shots are great for it. You can try the PRP if you can get it approved for that. It's kind of a newer thing. Mixed results in the science on the PRP injections, the platelet-rich plasma. The shockwave is good. I really try to avoid surgery for plantar fasciitis just because it only works about 80 to 85% of the time. So it's not a really, really high percentage play for the surgery. There's nothing wrong with doing it. I have to do one this week, but I really try to reserve that for people that have had tried everything. Physical therapy can be great for it too. Icing, and I give a bunch of stretching exercises.
Yeah, can ankle fusion lead to overcompensation by the knee and hip joints and possibly?
Yeah, good question. Yeah, good question. So there's some relatively recent studies on that, and if your ankle's fused in the correct position at like a 90-degree angle, you probably do pretty well. Over the long term, your chance of getting arthritis is higher than a non-fused ankle, and your chance of arthritis is probably lower if you do have an ankle implant. Your chance of arthritis in the knee is probably lower. Now, the real problem is when people get their ankle fused and it's not at a 90-degree angle, but it's a little less, so the forefoot is a little bit down too far. That's when you get overcompensation in the knee, and it hyperextends your knee every step you take, and so it causes uneven wear or unnatural motion on the knee. And then, then you certainly can get problems with your knee or even your hip.
With my pain, when I tiptoe and raise my heel, I do hear that pop. So what do you think is that?
Yeah, well, that can be a couple different things. On the outside or the lateral part of your ankle, you can actually, the peroneal tendons will sometimes do that, and you can actually sublux those tendons, which can be a really big problem. You can get some clicking of the joint below the ankle called the subtalar joint as well. That can do it. It can be a whole bunch of things. Yours, you might want to actually get checked out because yeah.
Okay, sounds complicated.
Well, let's thank Dr. Van Gompel